So, welcome everybody to our Fall 2025 Professional Speaker Series. I am so pleased to introduce Dr. Arthur Baker, who is a recent SAGE grad, but has gone on to do quite a lot in the year and a half, 2 years he's been out. Arthur is a physical therapist originally from Port Washington, New York. He completed his undergrad studies in bio at SUNY Oneonta, where he was a member and captain of their NCAA baseball team. After graduation, he worked as an NCAA assistant baseball coach and as a scout for Team USA, NTIS, and Prep Baseball. Arthur went on to earn his DPT from Russell Sage College in Troy, New York in 2024. Following his DPT, he completed a sports physical therapy residency at Midwest Orthopedics at Rush in Chicago, Illinois, where he had the opportunity to work with a variety of athletes ranging from high school to professional levels. Arthur is currently the Upper Extremity Athlete Fellow at Memorial Hermann Rocket Sports Medicine Institute, where he is integrated with upper extremity research, D1 University of Houston Athletics in baseball, and is looking forward to his transition in January to the Detroit Tigers Baseball Club, which is MILB, as part of his fellowship training. With a background as a baseball player, coach, scout, and former patient, Arthur specializes in shoulder and elbow care for baseball players and other overhead athletes. And we've invited him today to speak with you about some of his experience with technology and upper extremity rehab. So welcome, Arthur. And before we get started, just so everyone knows, he has a presentation with time at the end for questions. But if you'd like to put a question in the chat, you can, and I will do my best to facilitate that if we need to. Other than that, Arthur, you can take it away.
Okay. Awesome. I'm going to try and share my screen here. Let's see if we can. Can everybody see the presentation, the PowerPoint?
Yes.
Okay. So for today, we're going to be talking mostly upper extremity, residency fellowship, rehab technologies, and current concepts of upper extremity. It's something that is near and dear to me, but I feel like going into a deep dive just gives you a better understanding. So I hope everyone enjoys the presentation. So a little bit about me. I am, like Dr. Salvatore said, I did my undergrad at SUNY Oneonta. Then I did my undergraduate, or I did my DPT program at Russell Sage College. Let me just see one thing here. I'll go back one. This did not. Second. Okay, so we're going to backtrack for a second. This is the first slide. So first slide being, do you really have to keep an open mind? Yes and no. This was something that was said to me over and over again as a student, and then as a resident, and then even as a fellow. So it is near and dear to me as something that you hear a lot. And you try and look at it and you go, what does it mean? I think sometimes it can take you in the right direction. Other times it can make you question what you're passionate about. So the answer to that question is really yes and no. Being open-minded with your methods and perspectives that you're going to hear from different people is very important. But I think what gets lost in the translation is you don't have to change what you're passionate about. For me, I always knew that baseball was going to be my path. That's okay. It's just reframing how you take in the thought process of when people tell you keep an open mind. So with that being said, this whole bio right here was basically me being very focused on my goal. You know, from undergrad being a college player to, DPT at Russell Sage. You could ask Dr. Ramsey and Dr. Salvatore. I think day one I told them I was like, I want to work in professional baseball. So through sports PT residency, which was at Midwest Orthopedics at Rush in Chicago, the current upper extremity athlete fellow down here at Memorial Hermann, and then with a variety of baseball work experience, it's okay to know what you're passionate about and follow it. So how did we get here? This was what happened to me as a player. So I spiral fractured my humerus throwing to second base my sophomore year. It kind of took me down a path where, you know, I ended up rehabbing it once, fractured again underneath the plate, came back again. They rushed me back. So this is kind of like where it all started. What, defining your why. This was how I ended up in physical therapy. So, at least for the objectives of the PowerPoint today, I want to provide an overview of post-professional opportunities for those pursuing sports physical therapy and treatment of the overhead athlete. Um, Provide information and understanding of rehab technology used in high-level sports rehab, and discuss current concepts of upper extremity research. So, first, having an understanding of what is PT residency and fellowship education. So, I'm going to keep this kind of focused on sports. That's what I went through. Just understanding there are a variety of different residencies and fellowships available to those who aren't necessarily interested in sports. So, residency training is a post-professional structured program designed to significantly advance a physical therapist's skills and knowledge in a sports specialty area. That's straight from the APTA. There are 5 competencies that are typically associated with these accredited programs. So it's advanced specialization, intensive and immersive clinical experience, a focus on education and research, advanced mentoring provided by clinical specialists in the field of sports, and it's to provide acute emergency response skill set to be on the sideline of sporting events. You can see SCS plus ERA cert, that's emergency response for the athlete. That's typically something that is required prior to starting your sports residency. It's really just an emergency response course that, is important to allow you to be on the field for that residency training. Fellowship training is a planned post-professional program, advanced clinical and didactic education for the physical therapist who already demonstrates clinical expertise. In the sports realm, this is divided into 2 categories, typically upper extremity athlete, which is what I'm doing down here at Memorial Hermann, and then the Division I athlete, which rotates through football, basketball, and then college baseball. So it's kind of those are the 2 splits. So the image in the bottom right of the slide is what you'll see if a program is accredited. So that means they have to abide by certain rules and certain regulations to give you the experience and information that you need to be on that road to becoming a specialist. So something to look out for. So my emergency response story. This was patient 0. This was the patient I did not think I was going to have. So this is my best friend, Zach. We were at a bachelor party trip right before our friend's wedding. I had taken the emergency responder for the athlete course a couple months earlier, and I was starting my first job on Monday. So I hadn't even treated anybody as a licensed physical therapist yet. He's going down the lazy river and he dislocates his shoulder. Everyone looks at me, goes, "You're the only one that's a qualified healthcare professional here." And I was like, I haven't even started my job yet. I was like, this is, everybody's going to look to you, right? So long story short, I ended up taking his jersey off. He was wearing a baseball jersey, turning it into a sling, and getting him to the emergency room where they reduced his shoulder. Point being is some of those skill sets that you gain through this training goes way beyond just the clinic or way beyond the field. He's forever grateful. I tell him he's patient 0. He's going to end up in every PowerPoint that I give. But it goes to show you that you can help people not just in the realm of clinic or on the field, but even your friends and family that may have that situation happen. Okay, so my sports PT residency experience. Well, I was at Midwest Orthopedics at Rush. You have clinical appointment with protected percentage of athletic population, weekly didactic on advanced topics in sports medicine. I had the opportunity to be adjunct faculty at Rush University Medical Center, helping out with their OT program. So there are involvement in teaching and research opportunities. There was a research opportunity I had with one of the surgeons. So that kind of area is what you make of it, and each program is going to be a little different. The venue coverage that I had in residency was the big one is I got to spend 10 days with the Chicago White Sox. So that was really, really cool. I got to work with the Joffrey Ballet, which is a professional ballet company that tours worldwide. Got to run a medical triage team at the Chicago Marathon, work with the Chicago Steel, and then get a lot of hands-on training at Oak Park River Forest High School. So go Huskies, but you don't have to judge the tape job in the right hand corner. So learning experience. So part of this training, which is important to note, is because this training is to allow you to be on the field, there's a huge emphasis on your relationship with athletic trainers. So pretty much all of these experiences you're either working with or under, or they're your colleagues in this setting. So it's important to note that those people are very, very important to your experience in a sports residency. So then this is the Upper Extremity Athlete Fellowship at Memorial Hermann Rocket Sports Medicine Institute. So instead of a clinical appointment with protected time for sports patients, I have protected time for shoulder and elbow patients. The weekly didactic on advanced topics in sports medicine is mainly focused on shoulder and elbow. Typically a expert comes in, whether it's a PT from a Major League Baseball team, a massive health system, or a prominent surgeon will come talk about different topics. This didactic's a little bit different. It's a little bit more in depth than what you'll get in residency, but it's more you're kind of taking down the funnel a little bit. Additionally, I have MD collaboration weekly. So every Tuesday morning, I get to go work with Dr. John Conway. He was the former Texas Rangers team physician, really highly regarded within the shoulder and elbow. So we love to get to learn from them and be part of his team. There is a research publication requirement for the fellowship. So I put what my research I'm working on currently. So it's the prevalence of subclinical findings in thoracic outlet compression when thoracic outlet syndrome is not a primary pain generator or primary diagnosis. Apologies for the autocorrect there, but so you do have to write a manuscript. So it's important to keep your interest in research there. I did just get back from a professional conference in San Diego through ASSET, which is the American Society of Shoulder and Elbow Therapists, which I will plug at the end for anybody who's interested in becoming a student member. The venue coverage that I get through the fellowship is I get to work with the Division I University of Houston baseball team and the Detroit Tigers baseball club when I head over there to Lakeland, Florida in January. These are some of the pictures here. Some of it's didactic. We got to do some data collection with Sam Houston State. And then in the bottom left there is Dr. Conway. So here's some more pictures of just what my day-to-day looks like when I'm not in the training room or in the clinic. And without have to put in Rally Cap Red, Lance Perkins is the athletic trainer there. It is his dog, but it has become the team dog. So he supervises all rehab. So we get to hang out there as well. So next, we'll talk about some rehab technologies that we're using with the overhead athlete. Some of these are going to be, you can use these for both lower extremity, upper extremity. I'm going to try and keep it focused on upper extremity, but you can use them for both. So some of the rehab technologies we're going to be talking about is handheld dynamometry, biofeedback, blood flow restriction, wearable sword science technologies, force plates, and 3D motion capture. So first, we go into before we're able to talk about rehab technologies, I think it's important to address how people are testing muscle strength previously. So this is essentially your manual muscle test when it comes to athletes. So manual muscle test is a reliable assessment of strength, which may be obtained by MMT, but it shouldn't be assumed. It has a high inter-rater agreement for most muscle actions tested. Testers, irrespective of testing experience, show different force profiles with respect to starting force, maximum force, and slope of force, which is essentially consistency. So you read this and you go, well, what's the problem? Where's the gap? The gap typically is in return to sport or return to activity protocols, where they often have very specific testing percentages that dictate patients' ability to progress to subsequent phases or specific activity. Typically, these protocols are looking at limb symmetry index, so looking side to side, motion ratios like an ER versus an IR, or torque to body weight ratios that are normalized in the literature. So, for example, we'll give you a case. Patient is a 16-year-old right-handed pitcher with hopes to play baseball in college who you have been seeing in clinic for right shoulder pain. The MD team has just cleared the patient to start a throwing program. Based on the metrics here, would you clear this athlete based on the metrics on the right? You can shout out if you want. I don't know if they're able to.
You're allowed to.
It's okay. We'll move on.
All right, I say no.
Okay.
I also say no.
Okay.
So I'm with you, Katrin.
So that is correct. This is the same patient. So now when we look at this patient based on what we're finding with a handheld dynamometer to test side to side ratios and our ERIR ratios for an upper extremity athlete, this is not good. So this is now almost in the realm of unsafe to start them on a throwing program, regardless of if the tissue healing timelines that may or may not be on your protocol that you're provided are on there. So this is just to show that, not every clinic has the technology for this, and we'll talk about ways to kind of get around that. But it is important to look at if you're trying to treat these athletes at a really high level. So moving on to handheld dynamometry, the purpose is to accurately measure strength of a certain movement. Use cases would be ER/IR of the shoulder, scaption for the shoulder, and then knee extension strength for the quads. The pros, it gives you a really objective measure, something easily to track that you can do repeatedly and even capture small improvements or regressions over time. So it also provides you real-time feedback, and current literature suggests that an objective measure of muscle strength can be obtained using a handheld dynamometer. There are a variety of different handheld dynamometers. Some people like the Microfet, which is in the middle picture there. Some people like the Vald dynamometer. In residency, we use the Tyndek, which is on the bottom. That one's going to be a little bit different. That's a fixed point. So it takes out your own bias, how much force you're putting into the test as well. The force cage is on the bottom. I put that in there. Typically, most clinics will not have a force cage. That's typically what you're seeing at the professional level. It is a very, very expensive piece of equipment. So if you're fortunate enough to use it, it is great. If you can't get any of these technologies because they're too expensive, Amazon is fantastic. You can find a crane scale for $20 on Amazon to just make sure that you're not guessing with your testing. That's like probably the biggest takeaway from this is making sure that we are getting objective measures and making sure that you're not pushing down and saying, okay, they're strong. Here, go throw a baseball or a softball. Or so the next thing to go into is force plates. The purpose is to note variances in asymmetry and force curves during dynamic tasks. Its use cases are mainly for lower extremity, but can be used for upper extremity as seen in the picture to the right there. It's typically used for squat assessment, jump asymmetry, reactive strength index, which is how fast they're moving off of the plates, and balance, and upper extremity isometric testing, typically in that long lever position with the arm extended. This is also super important because even as an upper extremity athlete fellow, we're not just treating the shoulder and elbow, we are treating the entire kinetic chain. So it's important to be looking at everything from the ground up with these athletes. So this gives you a lot of good information. They're even putting it into mounds at the upper extremity level with some of these professional teams, which is the picture down in the middle there. And it gives you some really good information on how the athlete's moving and are they at risk for future injury. The next is biofeedback. It's to quantify how much voltage is going through a certain muscle. It's typically used for neuroreeducation. We see it used with the serratus anterior with overhead exercises. We'll typically put some of those pads on the low trap or upper trap to see if, at least in the low trap case, we want to see that number go up. We want to retrain that lower trap and downregulate the upper trap with overhead motions. So we're able to quantify and track how much millivolts they're producing over time. It's important to just be consistent with your pad placement for this. The technology isn't super expensive, so if it's something that you feel is going to be valuable to your practice, the M trigger in the top right is for a clinic shouldn't be that much of an investment. The pros are it shows real-time feedback and effort level. It's more active approach to rehab, and it can help the patient find the muscle they're looking to activate because they're getting that feedback right in front of them. The M trigger is great. I've used this a ton. There's games on it, so you can have them activate and move a ball. You can have them move a car. There's different ways to also keep the patient engaged. Next is 3D motion capture. So the purpose is to be able to assess athlete kinematics with precision. We typically use this in like a throwing analysis to identify fault in kinematic and biomechanics leading to increased risk of injury, and the ability to break down specific dynamic movements to ID impairments. Very, very, very important. If you don't get anything from this presentation, athletes are expert compensators. They will trick you all the time. They are super strong. Even if they're coming in for something, their body is really, really good at finding a way to trick you into thinking that they're better off than they are. So this is a really good tool if you have access to it to kind of break down what those faults are and where they're happening. There are two types of 3D motion capture. The gold standard that you'll see in research is markered, which like if you see people with the little dots, that little sticky dots on them, that's typically and still the gold standard, but now they're coming out with markerless technology. So to make it more affordable and more accessible for clinicians, coaches, etc. Even right now, they have them inputted in the stadiums. They can get real-time biomechanic data in-game. Next would be blood flow restriction. So the purpose of blood flow restriction is to overload the muscle with reduced load to the joint and increased recovery. This is super helpful in your post-operative phases when you cannot load the joint based on the protocol. It's an easy way to challenge your patients, keep them engaged, and also have really, really significant benefits in those early days that kind of feel like you're kind of dragging a little bit. So its use cases can be contralateral limb in a massive rotator cuff, for example, or post-op shoulder elbow pathology. You're typically going to put that as high up as you can to get the most benefit there. The pros is great for building muscle when the joint can't tolerate load, and it's evidence-based. The current literature, I gave you some like limb occlusion pressure if you do have access to one of these to kind of use as a reference. Upper extremity found a diminishing return at 50% limb occlusion pressure. This was in a 2018 article by Lambert et al. And then the lower extremity found diminishing returns at 80% limb occlusion pressure. That's essentially how much blood flow they're letting through. So for 50, they're letting 50% of the blood flow through. For lower extremity, they're only letting 20% through. They can tolerate a lot more for lower extremity. The research also suggests that it increases serum growth hormone, IGF-1 and testosterone amongst athletes. So I just had this happen to me. A couple athletes didn't want to do it. They were like, I think it's a hoax. I brought up a paper. I said it increases your growth hormone, and the college athletes were all in. So however you get them to do it, it can be helpful to educate them as well. And it also has a systemic effect on muscle hypertrophy. So even if you do it on the opposite arm, they are finding that because of that systemic effect of growth hormone, IGF-1 and testosterone, you're getting benefits even at the area that you're not necessarily treating at that time. Wearable sports science technologies is next. It is kind of a growing area of sports rehab. I don't think it's at its peak yet, but people are starting to adopt it more and more. The purpose is to track stresses of dynamic motion in real time and provide data on how athletes move in their sport. Here are two use cases that I've had experience with. Pulse Driveline is a company. Driveline's the company. Their Pulse sleeve is used to monitor valgus stress and workload across the joint. So typically they put that like sleeve around their arm. They go out and throw. It will track number of throws. It will put that into a calculator of that, how much they're throwing in the short period versus the long period. That could be a whole nother talk for another day, but that is called the acute chronic workload ratio. But it is tracking a lot of that data, both from a coach's perspective on when should they be ready to throw next, and then from a sports medicine perspective of, well, are they at risk for injury because their valgus load increased? Catapult is being used heavily across multiple major league teams at this point. They have it down to a science, quite literally. My experience when I was out in spring training, they were tracking bouts of high speed running and were able to manipulate on a daily basis in the sports medicine meetings how many bouts of high speed running they needed to meet their criteria for the week versus another person who was capped out and may have gone over their limit. They knew they needed to cool them down. So they're using this to monitor workload, not just in the body part that you would typically treat, but just the whole person. So the pro, it allows sports medicine teams and sports science teams to track athletes' workload. It is a big thing. These guys want to move. You know, if they're trying to make a team, they're going to try and overdo it. If they're stressed about a scholarship, they're going to try and overdo it. So this kind of gives you good insight and kind of a leg up when you go into those meetings to be like, hey, we need to cool this person off for today, or hey, we need to push this person. So the next thing we'll talk about is humeral retrotorsion. This is kind of current concepts. We're going to take a break from rehab technologies for a second. Humeral retrotorsion, in a nutshell, from what we used to understand, is it kind of explains why maybe what we thought about GERD, glenohumeral internal rotation deficit, we may not have really had the whole picture, essentially. So the two factors from a humeral retrotorsion perspective is you're actually born with your humerus in a more retrotorted position. As you age, developmental derotation process occurs. So at birth, the humeral head is in a marked retrotorted position, and over time, it goes through a derotation process during the pediatric and adolescent years. So it basically comes from this rotation, and then as you age, it kind of rotates forward. When talking about an overhead athlete, you have adaptive torsion as a result of muscular forces acting on the humerus. So opposing rotational stress is imparted by muscular forces above and below the proximal humeral physis exerted by the external internal rotators. So essentially, that's what they're getting when they get back into what we call layback position in a thrower. You can imagine that like T-ball happens very early. People are now getting into sports specialization. You can imagine that constant getting into abduction and external rotation over and over again really slows down that process of derotation. So humeral retrotorsion, the overhead athlete, the throwing arm demonstrates greater humeral retrotorsion when compared to the non-throwing arm. Differences can be seen between sex, limb dominance, and race. This is more research that have come out of, they found that the Latin American baseball players have more retrotorsion than some from other countries. So they're kind of linking it to potentially be a genetic component there as well. Or, yeah. So then what about age? Hibbert et al. Found the largest side-to-side differences in junior varsity and varsity baseball players. This is likely due to sport specialization and higher velocity, i.e. more opposing torque on the humerus. This is important because this is typically when people specialize and they stop playing other sports. So it is all year round. So it's important to realize that rotation isn't, you're not getting a break there. Also, now everybody's chasing higher velocity in baseball. It gets you paid. Nobody's going to deny that. But we, as healthcare professionals, should be wondering what is that doing to the athlete in front of us. So this is a concept that I didn't understand until I got to fellowship. So I don't expect everybody to understand retrotorsion today. You don't need to be an expert, but this just lets you know why we're looking at it. And in the nutshell, like for 20 something years, we thought GERD existed. So I hope that you get out of this is that you are the next phase of therapists. You should constantly be questioning the research and see, are we missing something? Because we didn't even know that this was possible for 20 years. Everybody was GERD and giving a sleeper stretch, which I'll talk about here in a minute. But case example is patient is a right-handed pitcher that has been going to physical therapy at another clinic that does not have knowledge of humeral retrotorsion in the thrower. Their PT has been prescribing the patient a sleeper stretch, active assisted range of motion for internal rotation to improve patient range of motion, citing GERD as the main impairment. You test torsion and obtain the following data. So the actual calculation I put underneath in the slide here, but if you do the calculation that's on the slide on the right, you actually, when you account for retrotorsion in this person, they actually have 0 degrees of internal rotation. So we'll walk through that. External rotation measurement was 95 degrees on the right, 108 degrees on the left, so a difference of -13. Internal rotation was 26 and 40 degrees with a difference of -14. These measurements are typically done in comparison to their throwing arm. Total range of motion was just external rotation plus internal rotation. And then their humeral retrotorsion, the way that they do it is they get a number based off of the measurement that they take at the deepest part of the bicipital groove. They do it with like an ultrasound technology. So they're comparing that torsion, so that relative HRT to side to find the difference, which is then used in the calculation. When you plug all those, well, first, when you look at this, you go 26 degrees. I'm going to give this person a sleeper stretch. You go, there's no way. That's way too little. And then when you run it through the calculation here, which is really just their ER, their ER difference for external rotation corrected, it's their ER difference plus their retrotorsion difference. And you get minus 27 degrees. So that means that this person's actually lacking 27 degrees of true glenohumeral external rotation. When you take the calculation and you do internal rotation, you subtract the HRT value and you find out that this person's not missing any internal rotation, true glenohumeral joint internal rotation. This is going to be how you change your treatment from this. All of that hard work to try and get internal rotation may have been misplaced in this scenario. They actually end up lacking external rotation when you correct for the twist in the anatomy. I typically use this example because I did work with some professional dancers. We account for the change in anatomy in a dancer's foot with the bone changes from them being in point, but we haven't seemed to catch on to adapting our treatment philosophy for throwers that are going to have the same bony changes or different bony changes, but in a similar light. So what problems could be present if you continue the course of care originally prescribed? This is what we've been doing for the past 20 years. We have been creating dynamic posterior instability in a thrower because we have been hanging out on that capsule for 20 years. I think that this is kind of the next wave if, as things become more affordable, but it's just something to keep an eye out for. So HRT clinical bottom lines. You must appreciate the bony adaptations and changes to the body as a result of sport. Humeral retrotorsion can impact true glenohumeral range of motion measurements, and humeral retrotorsion is often present in your overhead athletes. Up to 80% of your overhead athletes diagnosed with GERD actually have true glenohumeral external rotation range of motion deficits and not internal rotation range of motion deficits. This is backed at the fellowship that I'm in right now. We have a research team, so this is backed by current literature, but also what we're seeing on the ground here when we measure patients before they go see Dr. Conway every day. So it is definitely eye-opening when you go, wait, I've prescribed a sleeper stretch to somebody, and it's nobody's fault. That's just what we thought the current literature was at the time. And it's not to say that some people don't have an internal rotation deficit. Mainly the reason I put this in here, one is it's new research that's coming out that I'd love for you guys to be aware of, but two, it's okay to question what has been done and question and use that to form your own clinical expertise and clinical questions moving forward. That's going to be good for you, good for the profession, and also good for your patients. So I think that's really important. This picture at the bottom here is basically showing how they take the measurement. So they're looking for the deepest part of the bicipital groove, and that's typically where they take the measurement. They're using an ultrasound to find that point. So most places don't have an ultrasound lying around, but just something to keep an eye on. This was a pet peeve of mine back then and a pet peeve of mine still now. So there are 38 references for up to date, and you don't need to read them all, but they're there for you all to take a look at. At any point, if you guys want to reach out, this is my contact information. I'd be more than happy to set up a time to talk with people who are interested. And then any questions? I know that was a lot, so tried to get through it, but
What are some of like the more interesting cases that you've seen, especially for upper extremity? Something that kind of threw you for a loop for like a little bit, especially when figuring out like what was causing their issue,
Mhm.
and then once you figured it out, like what was it?
So I'll give you two. One was a former Division One gymnast that I saw in residency, um, who had a UCL or UCL repair in college. I got her up in Chicago. She had a revision of a repair with an ulnar nerve transposition. So she was having nerve issues on top of trying to rehab her, you know, UCL or her typical Tommy John ligament. I thought the tricky part of her case was you see Tommy John, you think overhead athlete, you think baseball player or softball. Or what was difficult was there were no protocols, there was not a lot of research on how to get somebody back to like a closed kinetic chain sport. So we kind of developed our own based on progressions, um, and kind of went with tissue healing timelines, starting from the basics of just getting them used to having pressure in their hands, all the way up to a handstand. Um, so I think that one probably was one that stands out to me in residency as like a tricky upper extremity case, just because you think, okay, I'm going to have it on a platter. They're going to give me a protocol. I'm going to check the box. And she showed up, and me and my co-resident looked at each other and went, "We're going to have to figure something out." So it's just relying on the information that you get from your professors and your experience that will kind of help guide that. Those like murky waters that aren't so clear. I don't know if that answered your question, but
That did, thank you.
yeah.
I had a question as well. How do you go about kind of communicating with coaches with all these guys that throw from different arm slots? Like it puts a lot of different stress on different structures, and some guys kind of just stay with it because it works. So like, how do you go about making changes with that?
So that's a good question. Typically, how we're managing that is we're not the pitching coach, right? So when they come to us, we're not necessarily making changes to their arm slot, especially at the higher level. They're going to look at you and say, I just got paid $300,000 from throwing from this slot. You can take your opinion and for what it's worth, right? So realistically, our job in that scenario is to make sure they have the capacity to make the changes that the pitching coach wants. So from a let's say the pitching coach wants to make them go overhead, well, we got to check if they're strong enough, if they have the range, if they have the coordination, to be able to actually get into the movements that the coaches want. On our end, we're not necessarily making changes at the higher levels. They have pitching coaches that are getting paid a lot of money to do that. I think that changes once you're in a clinic because you have to wear more hats. Um, like more of your outpatient clinic that doesn't have access to a pitching coach, or I think that becomes more challenging. But I would think you're part of the team, you're part of the equation is to make sure that they have the capacity for that. you know, most guys aren't necessarily going to change their slot unless they get hurt, maybe. And then that's a conversation with the pitching coach, the player, and kind of everybody involved in the care.
Thank you.
Mm-hmm.
Well, I have a couple questions because, of
Okay.
course, I do. I
Yeah.
always come prepared with questions. So, um, one of my first questions is actually about ultrasound imaging, which you kind of touched on. So, I know there's a
Mhm.
certification for some physical therapists now to get point of care diagnostic ultrasound training. Is that anything you're seeing at the residency or fellowship level now that it's an expectation that people at that level are doing more point of care ultrasound?
I think in the clinic it's tough where I am because we just have so much access to the docs teams.
Mhm.
Dr. Conway and his team work on the 17th floor, so having the access there. On the field, they have so much access to like MRI, X-ray, like they can just get it done right away. But I did when I was on the clinical when I was in your position and on clinical, we did see that at Dr. Meister's clinic in Arlington. They were using point of care ultrasound. I think it's valuable for an acute injury. I think it's a good certification to get. I just think at the professional level, they're very quick to just put them in an MRI machine when they're paying them a lot of money. So it's really just a matter of resources and what you have access to. I think it couldn't hurt.
Yeah, that's really interesting. My next question is sort of just about tech specifics. Do you have a preferred blood flow restriction brand? Because I know some of them do not make it easy to find that occlusion pressure. And that's always
Mhm.
been one of my hesitations with recommending that, because if you don't have like one of the good ones, who's to say you're at like an optimal pressure, right?
Mhm. I would say the Owens recovery system is tough. I like it the best, but it's the toughest to get. You have to be certified through Owens recovery system in order to be able to purchase their device. So some of these teams kind of have the workaround and they get one person certified to buy the units for the rest of the team. But two really good units would be Smart Cuffs and I think it's Uji, or it's a Japanese brand. That one's good. I could always get you that information, but I like the
Cool.
ones that change when they do the exercise. Some of the ones are like pump up and you just leave it. You have no idea as the blood flow is changing as they're going through the range of motion. So I think the Owens recovery system does a really good job at like adapting that to when they're doing a squat or they're doing an overhead press. Like it's constantly adjusting to meet that optimal occlusion. That's what I saw used at spring training. That's what the White Sox used. So, but that's what we use in clinic here, but I've also used the smart cuffs in clinics for residency. So both have been found to be beneficial. So those are my
Awesome.
two.
I have a question. Wait,
Yeah.
Tara, it's my turn.
Yeah.
Yeah, go ahead.
So, from the student's perspective, right? How do you feel
Mhm.
like work-life balance in residency or fellowship is compared to, the route of graduating and taking a job in an, outpatient clinic? Like just so that they could maybe better prepare themselves as if they're entertaining that. Is it
Mhm.
like more of a workload, more hours, or like yesterday you were off doing something on a Sunday afternoon, you were still working.
Mhm.
Yes. So just let us know about that.
Yeah, I think from a workload, it's very different, right? So school was very different in the sense that you go to class, you can study, you have your exams that you need to prep for, you have lab, but it's not you're actually given time to like do those things um outside of class time. In residency, it's very different. You're I mean, I can go through my week in residency. I worked half days. I worked the afternoon on Monday, Wednesday, and the mornings on Tuesday, Thursday. The afternoons were spent with venue coverage, So I think it was definitely more time consuming than school. You're also, I think, trying to figure out how to be a clinician. I think that was the hardest part for me was they go, "Okay, here you go. You're gonna be a specialist." And you go, "I just graduated. I'm trying to figure out how to be a PT first." So I think the first 3 months of residency, and that's pretty, um, across the board from my friends who've gotten through that as well, is those first 3 months are really tough because of you're trying to figure out how to be a PT and a specialist at the same time. Uh, Time management super important. Things change. Sports is crazy. The schedule can be all over the place. You could be working a Friday night lights game until 11 o'clock at night because of a rain delay, or at midnight because of a rain delay. Um, and you just have to be able to kind of roll with the punches and have a little bit of flexibility in your schedule. I will say it was very hard to get to every wedding I had to go to last year, but we made it happen. So it's just, I think it's 1 year of like really really hard work for the potential benefit for the rest of your career. So I think if you approach it from that perspective, that it's important to make time for yourself, but you have to be intentional about the time you make for yourself. Um, that will be kind of big. But everybody who goes through residency will tell you that you know it's definitely a lot for sure. I don't know if that answered your question, but yeah,
Thank you.
Hi,
you
Arthur.
know,
Sorry I was
hi,
late. I
that's
just
okay.
wanted to jump on and say hello. You know, I know nothing about upper extremity athletes at all. You work with any soccer players?
I actually did work a little bit with the University of Houston soccer team this past fall.
That's awesome. So we'll have to talk more about that.
Yeah.
But since I jumped in a little bit late, I was just going to ask you in your,
Mhm.
obviously you're very specialized, but how important is it knowing other systems? We'll take my favorite, like nervous system. How
Mhm.
often do you use any of your neuro skills crossing over with your athletes?
So more than you want to admit as a student, way more than you want to admit as a student. There are definitely different systems that you may or may not use, but from like talking about neuro, um, we have something in the works. Kind of, I was talking to Dr. Salvatore about this a little bit before we hopped on, about doing research on median nerve gliding and how it actually increases external rotation in throwers acutely. It's something that we see in the clinic. We're not changing any of the muscle elasticity, and we're seeing a range of motion difference just by affecting the nerve and downregulating the nervous system. My jaw was on the floor when I saw this happen over here. Uh, I was up with Dr. Conway. He called up one of the PTs that's been working here for a while. He gave a guy who is set to go in the major league draft this year nerve glides. They were lacking external rotation. 2 minutes later, he kicked back 25 degrees into external rotation, and I was floored. So I think we're kind of seeing, at least in the thrower, a big connection with neuro. So I think that's been super important. I had somebody the other day that had a suprascapular nerve injury that was presenting as like weakness in external rotation. So it's like very important to know your systems. It doesn't mean you're going to use them every day, but if you don't know them and they present and they find you, you're going to be in a tough spot. I think
I think that's a good message because I don't know if you remember when I first met you in my motor control lab, you told me I only want to work with baseball players. And I said, but I guarantee you those baseball players will have central and peripheral nervous systems. So I think
Mhm.
that's an important message that we might have our thing that we want to do, but as you can see, even in the specialty areas, we have to know everything. We have to really
Yeah,
understand how the entire body works.
yeah, and I think the farther you go through the training, the more you realize you're pulling from different things. Like I mean, neuro is a big thing we deal with daily here. in that way. But even when I'm going to work with pro guys, they were once a kid. They didn't just wake up and pitch for the Tigers. So understanding that, like we're even talking about the retro torsion as something that they're developing over time from a young age. So I think it's important to kind of take a holistic approach and then start to narrow it in as you go through like those advanced training, like specialization as well. I don't know. I think that's yeah, that's been my experience so far. So
Arthur, if you had to give one final piece of advice, if there's other questions, we can take those too. But if you had to give one piece of advice to all of our students, knowing now what you know, what's one thing you wish you had either paid more attention to before doing a residency, or that you want someone else to know before they might pursue a residency?
I think it's something that I kind of always knew or had, but I think it's something that I, even when I was on the interviewing resident side of it last year, people are scared to tell you what they're passionate about. It's okay to be passionate about what you are passionate about. If everybody was interested in the same thing, we would be in trouble as a profession. So it's okay to find your niche, and it's okay to be passionate about what you are. I think that oftentimes people get scared into, oh, if I pigeonhole myself or if I do this and that, like, no, it's okay. If you're a dancer and want to work with dancers, if you want to work in neuro or pediatrics, like, and that's what you're passionate about, don't let anybody shake you. People are going to try and do that along the way. And I think both are important. And I think, kind of to your point, it's making sure you find the people around you that support you, especially in the program. And then when you get into residency and fellowship, and grab them and don't let them go. And then the ones that are like maybe giving you advice that might try and derail you, those people are important too. They're all part of the journey. And I think when you can recognize that both sides are important, I think you're going to end up going a lot farther in the profession too. But yeah, if you find your people, like I know Dr. Elkins, I don't know if she's here, but she always says, it takes a village. Find your village, and if it's two people, it's two people. If it's three, it's three. If it's whatever. But I think the earlier you can find those people that are support you and push you forward, like you're going to be better off. I know there are certainly some people who were part of my journey and part of my village on this call, so I'm very grateful for them. And I would have never gotten to where I am now without them. So I think that's very, very important.
Kind of building off of that in terms of residency, during your pursuit of a program, I hear that you are very much interviewing them as they're interviewing you. What qualities were you looking for within the program?
Number one is going to be, are they accredited? Number one. I think that number two is going to be the mentorship. And number three will be the didactic. I think the mentorship is so important because that's why you do a residency. You do a residency for you to learn under specialists in the given area that you're trying to, become better at and become a specialist in. I think it's what sets apart self-study is you have access to these people. I also think didactic's important because some programs will do MedBridge as their didactic. That wasn't something that I was looking for. I wanted specialists in the field with experience that I could relate to giving these lectures on it, and I was able to ask questions. So didactic, mentoring, obviously accreditation, and then I would say honestly the fit. right? Everyone talks about the fit. It's not well described, but you spend I mean, as Dr. Ramsey was alluding to, you spend a lot of time with these people. Like, if you don't like them, it's going to be a really, really, really long year. So I think just getting a vibe for the program, reaching out to the directors, reaching out to the faculty, just asking, "Hey, do you have like a half hour to chat?" I think can be really important there. I mean, when I was looking at programs, that's what I was looking at. I also wanted to go to a program personally that had baseball experience to set me up for fellowship training in baseball. So, you know, I think that's kind of another big component too. If you can find one that meet the top three that also have a lot of experience in the area you're looking to go in, that can't hurt.
Thank you.
I have a question as well.
Mhm.
Hello, can you hear me?
Yeah.
Um,
Can hear you.
so, for undergrad and also for your residency, I was just wondering, is there anything like if you could go back, you could do differently? And also, who was your favorite teacher when you were at Russell Sage?
So from a what I could do differently perspective, um, I don't think I was a non-traditional student, right? So I went back at 26 years old, I started the program. During the time I was going through it, I went back and forth, on, oh, I wish I started this earlier, right? I'm a little older. It was just something that went through my head sometimes with the program. As I've gotten out, I think everybody's journey is going to be unique, right? And I think some of that is beneficial. So I don't think I would have changed it any other way, um, from a program perspective or right. Like I think maybe apply to one extra program, but that's like in the grand scheme of things, right? There's no like magic bullet. You got to put the hard work in. So I think that I wouldn't have changed anything. And there's way too many professors on here that were positive influences on where I got for me to answer that question. So
I would like to say on Arthur's behalf, I think what stood out to me besides his thirst for knowledge was he worked very diligently at establishing relationships with faculty, establishing relationships in his clinics that he attended, right? All the people that he meets along the way, he goes above and beyond to maintain those relationships. And that's kind of unusual in somebody that's young and has their eye like on a big prize in the future, right? And so that's one of the amazing things that he does that I think has made him successful for sure.
thank you, Dr. Ramsey.
I have a question. So you knew relatively early on what your passion was and that you wanted to be specialized for like upper extremity. I know you talked a little bit about being like open-minded and stuff like that, but how did you handle like going through like clinicals and stuff that may not have reflected your passion or like demonstrate to you exactly what you wanted to do?
Yeah. So for context, I spent, I think it was 12 weeks in a skilled nursing facility or a brain injury center. I think your experience is going to be what you make of it, right? If you go into it and go, well, I don't want to be here, right? I'm just going to do my time. You lose an opportunity to learn something that may come back and wrap around on the other end. Like at least the experience in the brain injury center for me, like I was dealing with blood pressure readings that I didn't even think were possible. So from an acute management perspective, even though it wasn't the population that I was going to end up treating in the future, if you can find, and this goes for classes, this goes for clinicals, this goes for anything, if you can find a way to relate it to what you want to do, it makes it a lot more palatable. So like find the one thing that at that clinic or that in that clinical that you can draw in as being a skill set that you're able to bring to your next spot, knowing that that's not going to be the end all be all for you, I think is really valuable. And I think that goes for classes as well, that, you know, you may not be super, it may not be your like jam, but you know, if you're able to find a way to like tie it into what you're interested in, it makes it a lot better of an experience for you and the people around you. Believe me, I was not, you know, signing up to work in a brain injury center, but the experience overall ended up being really fantastic. So you'd be surprised, you know.
Thank you.
Yeah. I'll also say to that point, they actually gave me time off during that clinical to go interview at residency programs. So if you're open and honest with them, they'll work with you. You know, they don't know, they know everybody has a requirement, you know, but if you're willing to put the work in and show them that you're willing to learn from them, right? Like they didn't have to give me time off to go interview. That's not something they had to do. And it's kind of just the relationships you make with those people that and the respect that you give them, even if that's not something that you're going to go into. You know, especially like, you know, not to be funny, but like if you end up there one day, you want people looking after you. So, um, you know, just keeping that one in the back pocket. So I think it's important to recognize that as well.
Any other questions for Arthur?
It can be anything, residency, fellowship. I got.
Yeah, I have a question. So in terms of picking a residency and everything post-grad, do you recommend just if you want to do a residency, just go ahead and do it right after you graduate, or do you think it would be more beneficial to take the first couple months to figure out how you're what kind of like therapist you're going to be before you're deciding a residency?
Yeah, I think that's a good question. I think there are different ways to do it, right? I think if you, some people feel ready right out of school, and they're gung ho and they're ready for the grind and they're ready to kind of take on that next step. Some people need a little bit of time to figure it out. I don't think there's one way to do it. I'm biased. I went right into it. I thought it was helpful for me because I was I mean, they didn't let me create bad habits because I had eyes on me from day one. And I had the population that I wanted to treat from day one. So I think from that perspective, it's good. But like I said earlier, you're also still trying to figure out how to be a PT during that process. So I think it's a great question. I think it's depends on the person, depends on what you're comfortable with, and you know that would be my take on that for sure.
Thank you.
Hmm.
Okay, well, if there's any others, please unmute now. Otherwise, I put a link to the speaker eval form in the comments or in the meeting chat. So if you could take the time to fill that out, it's like a 5-minute form. The name on it is optional, but I will provide Arthur with that information. It's always helpful to our speakers to know what our students thought. but I would like to extend a thank you to you for giving us your evening, which I know is very busy. We definitely booked this like a month out because Arthur is got a busy schedule with all of his teams right now. So I want to say thank you for that. And I will be sending out the PowerPoint and a recorded lecture of this by the end of the week. Are you okay if the folks contact you directly through the email that you listed on your PowerPoint?
Yeah, they can contact me directly. I'm always talking to students interested in residency, people interested in fellowship. It's pretty much, honestly, at this point, constant because it is that season, that time of the year. It's something that, if you guys are interested and want to reach out, I'm more than happy to set up a time to talk. The only requirement I have is that when you're in that position the following year and people reach out to you, you do the same.
Okay. All right. Well, thank you so much for your time, everyone. And please fill out that form if you can, and we will be all set for tonight. Have a great evening.